Good afternoon, everybody.
Good afternoon from New York.
Welcome.
You can hear
Hi,
us.
George. George and Keeney from Mount Sinai, New York. What do you have for us?
So here we have a case number 1, if you can show us the slide. 82-year-old female who actually presented with a non-STEMI, systolic heart failure with pneumonia, hypoxic respiratory failure, was intubated. This was way back in December 2018. At that time, after initial stabilization, we did do a cardiac cath, and the right heart had shown that she had moderate pulmonary hypertension and severe aortic stenosis. And then what we see is she did have coronary artery disease. At that time, we did a BAV so that she can get a stronger, better,
Bridge
and then
BAV,
treat.
bridge BAV.
And treat her and then see how she does. So she went to subacute rehab and then subsequently has gone home and came back to see us again in the here in the office. So right now she's here with us for further
Keeney,
management. Can you hear now? Can you hear us?
Ron, is this? Do you have volume?
We have some interruptions here and there on the transmission. It's coming and going, so we need some stability of the cable. But we hear you when you come in, yeah.
Okay.
Go ahead,
So
Keeney.
she did have a echocardiogram done today, which showed that her mean gradient is just about 15. Her valve area is about 1.1. So essentially, her VAV worked. She
We'll
did
have to
recover
get what she
and
said. Go ahead.
here for further management. So you have seen the medication there. So this is her
We saw the
LV
description
gram.
of the angiogram.
Yeah. So if you see the LV function today is about 35%.
Yep.
This is a right coronary artery. So she does have about a 70% lesion in the
please.
AV continuation.
Could you tell us what's happening from the back room? Is it
Go to the angiogram, please. Very good. Go ahead. Now they can see it.
We see the right coronary. We see that you have an impella there.
Yeah. So I'll tell you the EDP was about 18, EF 35%. So this is a right coronary artery with a disease in the AV continuation. But more important, you can see she has a ramus which was subtotal in December is totally occluded, which you can see.
Okay.
If you can show us the left system, we saw the right.
Yes, now we are going to the left. This is the LAD, proximal about calcific, 95%. Then the mid LAD, which is total, which fills via the bridge. And then you have a significant calcific diagonal disease.
And again,
This
the
is her,
ejection fraction was 35%.
Yes.
Yeah, more like 30%. A good a bridge BAV that seems to have worked well. The gradient is low, and the target today is the LAD and diagonal. Any questions from the panel?
Complex protective PCI. Any questions, Maurice?
Yeah, so this is the intent here is probably rotational atherectomy, or what are you intending to do for that LAD?
So our plan is to do orbital atherectomy.
Okay.
We plan for orbital, but let's hear what how people would approach this.
So one question, I know Maurice is very experienced
Some dye, so
in
that
the
we know we're
rotational, I
engaged.
could say now he's the father of the rotational atherectomy. But I want to hear what other things about, now you have protection, you feel much more comfortable, right, to do almost everything that you want to do. And you don't necessarily have to ablate everything. You want to make sure that when you get the stent will be expanded. So from that perspective, I want to hear, individuals. Jonathan, what do you think should be working here? And I know you say I'm missing imaging, but...
Well, no, I take a step back. I mean, the impeller's in, but I mean, the anatomy is sort of moderately complex in the LAD, but the EF is not that low. I mean, is this really a hard indication for an impeller? Does this need to be done as a protected case, or is this a case you could do with impeller on standby? That would be my first question. The next question would be absolutely use some form of calcium modification. This type of case in the UK now and in Europe has become a shockwave type case. This is where shockwave comes into its own in this type of treating a whole length of calcific disease in the LAD.
Yeah, so you have also shockwave, but you don't have the orbital atherectomy, right?
No, we don't. Not yet. Not yet.
Yeah.
So if
I
we can
think that,
show...
again, it is a legitimate question, but there is no doubt if you have an impella and you're doing complex PCI with any of those ablative the devices, you have some assurances that at least you don't have to worry about hemodynamics. Yeah, and my question to Kenny, are you planning to do it just for the procedure and take it out immediately, or you're going to keep it for another 24 hours?
The plan
we
is
will do only during procedure.
Yeah, the plan is to do the LAD diagonal during the live case. Then we carry on and we do the AV continuation branch. And hopefully the patient will be stable enough for removal, which is not what we expect.
I kind of agree with the point about the fact that you should, I mean, is it really the EF is bad enough? Yes, you can have it, it's safety. But in areas where you don't have it or you don't want to do it because of peripheral vascular disease or whatever that,
well, if you have contraindication, obviously you're not going to use it, but you can do it with, in the old days, what did we do when we did not have impeller, right? We used balloon pumps or we just used pharmacology. But if you can do it and it gives you peace of mind, then it gives you a little bit more ability to do maybe another vessel at the same time.
Yeah, I mean, this is a patient who has AS, and the gradient is low, but it's probably a low gradient, low output. So this patient has a high risk of ischemia.
Yeah, indeed.
You're going to be doing some complicated rotablation or CSI, and you're going to have ischemia. It's going to be the whole length of the LAD. You're right. In the old days, we just do it, and you see what happens. But I think
we don't want to live in the old days. We want to live in progressive, right? Okay, so go ahead and tell us what you're planning to do: rotational or
we have orbital atherectomy ready.
Yeah, we wire with a run through.
No, we wired
exchange with the over the end hole catheter for the Viper wire that is going into the diagonal, which is not a completely occluded vessel, and we plan to mainly target the proximal LAD and secondarily the mid LAD diagonal area, and with orbital atherectomy. So far the device has nicely advanced into the proximal vessel.
George, you want to tell us the consideration for orbital versus rotational?
Well, I think that it could essentially.
I mean, in this case, you could use either.
You can use either. That's right. No, but at some point we have to use only one during the case.
Yeah. Okay. So I see the orbital is there. You find it's easier to use, or it's the same in terms of ease of use?
Well, this particular case that you see going very slow with a low speed only, and we'll complete the case only with a low speed. And a little bit of a difference, I would say, is instead of rotablating the entire vessel, you go into the proximal area and then you advance a little bit more and you ablate the distal area, not necessarily have to ablate the full maybe 50 or 60 millimeters. You can do two discrete, maybe a 20 millimeter lesion and then the 10 millimeter lesion further down.
Yeah, so I think you mentioned a very important point to go slow.
Very slow.
That prevents you from getting into complications. Very, very slow. And you can go ahead and do it. As you can see, the hand is moving. My question here would be, when do you know that you are done? I mean, how much are you going to do? How many passes? And how do you determine what is...
Well,
so right now I do have some resistance. So I'm just going very slow. So you definitely will know when you have completed the atherectomy of the birth.
Well,
we do have some
we also
resistance.
we also listen to the noise, and at some point the noise becomes uniform and you can move it easily in and out, and you can see that the ablation is possible on the way in as well as on the way back. But we haven't ablating around the way back because we haven't gone through a through on the way
So,
in.
George,
There.
when you're doing this, George
Very good.
or Dr. Kinney, when you're doing this and you say, I can do 1 millimeter at a time and then skip another 2 millimeters and do the third one thereafter. Well, this is probably hypothetical. But did you do imaging or IVUS or something like that that speaks for the anatomy?
No,
No, we didn't do. We
we
thought
have
about it,
IVUS
but we
ready,
didn't do.
but if you see the significant disease in the proximal LAD, we were worried that IVUS will not cross that calcific 95% lesion. But
Yeah,
the
maybe,
point is
maybe.
very well taken that you need to
So, question
have
for
at least
Jonathan Hill:
severe calcium
if
before
the
you
IVUS
decide that
didn't
you want
cross,
to do
you
a
think the
atherectomy.
shockwave will cross?
Never.
No, it won't.
Never.
But in this situation, I think it's perfectly legitimate to use a 1.5 millimeter balloon. That's what we would
Go
do,
to
and we would
diag.
put in an OCT,
Go back
an
one more.
OCT catheter.
And then we advance
I think
to
the
the-
detail of anatomical assessment that you get with OCT in
You can do
comparison
the
to
thing.
IVUS
No,
is,
wait.
I think they're incomparable. You can see the depth of the calcium with OCT. You can see, the concentric nature of the
go
calcium.
forward.
I think
Wait.
much more clearly than with
advance.
IVUS. So
just advance your
I think we should be
parallel.
switching to universal OCT for
No, from here.
calcium
Advance your
assessment, especially in this type of lesion, because it can really direct your calcium modification strategy. I think at the moment they're going blind. They don't know
Don't do
where the
anything.
concentric regions are. They don't
Okay,
know
leave
where
it.
the calcium is deepest.
Yeah, that's why I was saying the thesis of being able to do a little bit, then spare, and then a little bit more
continue.
is a hypothetical, and that's why I did not think that necessarily it was a cogent point for this versus rotational
coming back.
atherectomy, but either way can be done.
Ziad, I remember we used to do laser in the old days when we worked together at Emory. You think laser has any role
Good, right?
here?
I don't think
Yes. Why did
laser
you do
has really much of a role at this
Okay.
I think we're
point.
good.
Coming out.
Although we've seen some
Right?
presentations
I mean,
yesterday in
Start
some
at
CTOs.
Dyna.
No, we don't need. We don't need.
Coming out.
So what are you doing now?
So
We actually went all the way to the diagonal.
As expected, the proximal lesion was very difficult. It took 6 or 7 passes across. That was completed with very stable hemodynamics, blood pressure 140/60, heart rate 78 all along. And then we advanced to the distal. That was kind of easy. It went to just a couple of passes, very easy, and we're done. And we're moving it now over the wire and get ready to wire both diagonal as well as the distal LAD.
So in general, Ron, are we seeing
Yeah.
are the orbital and the rotablator, are they being used interchangeably, or are there clear indications one way or the other?
Well, it depends on the beholder, but the recognition, if you really want to ablate and it's heavy calcified, rotational atherectomy would do a better job for you. Recently, if you go on the same line of the shockwave, you just want to do some modification, and even with rotational, we're not going to full ablation. We're
Get me the
doing
guy
just
already.
some ablation, but
3.
more gentle ablation, and all what we want to do is to facilitate good stent expansion. So for that, you don't have to go too high. So you have a lot of overlap. Again, I don't know if this case falls into the overlap. I'm 100% sure that if this was in Maurice's lab, he would have used just rotational atherectomy. And many people who are comfortable with it, that's probably they will do. Those who have orbital, they will tell you by their own experience. I mean, anyone from the panel wants to comment on that?
Yeah, maybe you can go back to 100 years ago when we did the experiments, and actually you take that same chicken wing and you do orbital atherectomy versus rotational atherectomy, and you try to see the rent that it has made into that. And clearly, rotational atherectomy is a bit more powerful.
Yeah, it is more powerful and ablative, more. But still we do very little of this. I mean, we have seen so many calcified lesions,
no need.
and we treat
Get me
very
the
few.
300 run through.
All right,
Could,
so the
so did
the
you
field
ablate
across
him
in the distal LAD, and we're doing a long exchange wire.
George or Dr. Kinney, could you comment on your approach with what you decided to treat first and the wiring, just thought process on that?
Right, you went to the diag as opposed to the LED, and did you ablate him to the diag, or I didn't see if you did
We
that or not?
ablated into
Yes,
the
we
diag,
ablated
and right
that,
now we
yeah.
just opening the
The LAD was a rather smaller vessel, maybe related to a prior MI, subtotally occluded lesion. The lesion is not at the bifurcation level, but further down. We didn't think this was worthy of a rotablation at that level. It would be more important to ablate something around the bifurcation and go from there. And that's what is going on right now. The filter went nicely in the distal LAD, and now we're going to use a 300 wire to exchange out the end-hole catheter and proceed with some ballooning.
Question that we get a lot of time. You have two wires, one in the LAD, one in the diagonal. You want to do rotational atherectomy. Is this a must to remove the wire from the diagonal, or you can go over
Yes.
that with any of those devices?
Yeah.
In my book, yes.
You always remove
Yeah,
it.
if you are doing OA
Guess
or
what?
RA, the side wire, side branch wire has to come out. Yes, it will cut the wire.
Yeah, I think that's
So that's really one of the big advantages of
Shockwave. You don't need
shockwave. So when we're treating left mains or bifurcations, trifurcations, you can have 2 or 3 wires down, and you can shockwave each limb.
If the vessels are large and you are in a pickle, I think we've done it several times, maybe, where you put the steel wire catheters and in the diagonal and take care of the LED.
And another question, if you do several passes with the orbital and you want to try the balloon and you see that the balloon is nicely expanded, let's assume I know that we all want to do imaging after every pass, but most of us are not doing it. So let's, poor man, imaging, you do the imaging in the beginning, now you did several passes, you put the balloon, you see the balloon is fully inflated. Is that good enough for you, or you still want to do more?
It's easy.
What
I
would
think
you
if
do?
you have a balloon expansion after you've done any kind of atherectomy, whether it's OA or RA, that's a good sign that you are ready to stent. If the balloon is not well
as long as you're
expanded,
confident
then
about
you have
the
to
size of the
consider.
vessel. Right. Because sometimes you're fooled that it does open up, but the vessel might be much bigger than you think.
Yeah, you have to use the right size balloon, or at least close to right size balloon.
Well, for
Doesn't have to be
this
high
ca-
pressure,
for-
but as long as
for
it's
this
safe.
Like you
case-
put in a 3, you see it's a 4 or 5 or something.
For this case, we plan
the
to
balloon.
use a 2.5 balloon for the diagonal and maybe even a 2 1/4 in the LAD first. We'll see how it goes.
2 or 12 you have, right, LED?
But we've all been fooled where you tried it, you say, I'm going to do only a 1.5 millimeter burr, and then you finish, you put a 2.5 balloon and then try it, and the stent does not expand fully. So you have defeated the purpose. Here, the purpose is to try to get maximum stent expansion, right? It's not debulking or anything else. It's maximum
Get me the
stent
2.5
expansion that could be documented on imaging.
Yeah, for someone who gets a lot of instant stenosis, I can tell you that at least a third of those are under-expanded stents.
That's right, yeah.
And it's really devastating to see it because
You're stuck.
even brachytherapy is not going to help if you have unexpanded stents.
Exactly.
So it is something that you have to invest a little bit before by making sure that before you put the stent, you can expand it.
Precisely, totally agree.
All right, so going
let's
with a
think of the
2.5 balloon now.
bifurcation. Yeah.
Okay, Kini, lead us, tell us what are you planning to do now? You're taking the 2.5
So
balloon?
essentially what we did is we cross the LED with the fielder, then we had a fine cross, went exchange with the run through there, and then we side by side wire of the fielder into the diagonal. We are dilating the LED to diagonal. This is a 2.5 high pressure balloon, go to 1820 atmospheres. And now I think it's a good expansion.
And now you could
but
see, if this were the LED, for example, you see how the under expansion and you feel...
Well, you can actually mag it, so we can...
Yeah, is this a compliant, non-compliant?
compliant.
That's another good point. That's another good point.
Yeah, so you would use compliant balloon.
Yes. Okay, go up.
I would personally use non-compliant if it goes.
Yeah, because it may...
Non-compliant. This is a non-compliant balloon.
If it
20,
goes,
and
No,
let's
sorry,
say if
this
it goes,
is
I would use non.
done.
This is a non-compliant balloon at 20 atmospheres.
Yes, that's good.
Non-compliant.
Jonathan
For the
Hill,
LED,
what do you
what
do
you
in the
want to
disrupt? You have to do pre-dilatation
Let's take a picture.
or post-dilatation. What balloon do you use?
We very infrequently do post-dilatation because normally by
I
the
would start
time
with a 2.0 in the
the
LAD.
shock,
2 or 20.
shockwave
2.020
treatment
in
has
the
been
LAD.
completed, the balloon, which is sized 1-to-1, is fully expanded. So
or
it's very
20.
rare that we will do
2.020
post-dilatation before we put the stents in, post-dilatation after the IVL.
You don't post-dilate
What kind of
stents, you
balloon
mean?
for pre-dilation?
No, so I'm talking about dilatation with a non-compliant balloon after the IVL treatment.
I think the question was
It's not
before,
required.
right?
Yeah.
I think, the
Before, I'm talking before you put the stent.
No, so we don't do another step. Very, very rarely.
Yeah, but in this case, you said that you had to pre-dilate this before.
No, so that's actually to get the IVUS catheter down or the OCT catheter down.
The IVUS doesn't pass. What do you do? Or the shockwave balloon doesn't pass.
So if the shockwave doesn't pass, we will put in a 1.5 balloon.
Compliant or non-compliant? That's where we were.
Yeah, we use these. We've got these. You've got little.
You use compliant.
Compliant, yeah. They're tiny little balloons, but the need for additional rotational atherectomy before putting a shockwave balloon in is occasional. It's not required that often.
Yeah, thank you. And you're planning on provisional here, or
that is something we can discuss. Do we do provisional or do we have to do two-stent technique?
Well, yeah.
We are prepared for two-stent technique.
20.
I think you need to, because it was a very disease from the osteum of the diagram.
Yeah, the other thing is you had mentioned that the LAD was mostly infarcted. There was an infarct there, so you want to definitely keep that diag open.
Yeah, and the question, if it is
It's a big
provisional, which
vessel
is the bigger vessel of the...
But you have to go
Is
with
it the LED or the diagonal?
But where's more
Let's go
viability?
by it with a 2.5 balloon.
It's down to the
2.5
diag.
cutting
No,
balloon.
we have it already. No, we have the one we have.
Which one? We don't have a cutting.
We have a 2.5 20 high pressure.
This is
The
2.0.
one we had 2.5 15 high pressure we had before.
No, I think you have to
It
cut
would
it.
be interesting now
So,
to actually image the vessel
we can
and
do
to look at the calcium distribution, certainly in that segment
we'll do
beyond
that.
the diagonal. I think that balloon did not dilate evenly. Certainly, there's
Also it'd be helpful,
calcification there.
and I probably don't do as much
So-
imaging as I should, but it's helpful to see how big the vessels really are. There's a lot of spasm here. You want to see, what plus when you choose your stents.
Plus, the vessels are diffusely diseased and small.
Yeah.
You have to
So
choose
we
what
go
stent.
with a cutting balloon, or you want us
Well,
to
they
do
appear
IVUS?
small.
Cutting balloon.
Yeah, we'd like to see some imaging.
OCT, please.
We understand better what's the
We have
inside of the
a-
artery look.
So you
Yeah.
used the
We
2.0
have the IVUS
balloon
ready.
on the LAD?
Let's do the balloon first. Well, we're going to do the balloon first, so we need to dilate with something a little bit bigger in the LAD and in the bifurcation. We'll try to do that first, and then we decide on imaging. So
So remind us which one was, you were talking about viability or maybe infarcted vessel in the LED territory. Is that what we
Yeah.
No,
heard?
we thought based on the angiography and echo where there was some mild anterior apical hypokinesis that LAD was an infarct vessel when she presented in December.
But viable still from the LV gram.
Yes.
yeah, based on the LV-gram, yes.
Okay, go up here.
Let's go up in the bifurcation. 2.5 cutting
Ruptured
balloon.
again.
So you used, so that's the cutting balloon or
Yeah, this is the cutting balloon.
2.5?
OA.
No, not OA now. Okay, get us a 2.4
2.5. Give
high
us
pressure or 2.75 you want.
2.5. Let's start the
Okay,
one we have.
2.5 high pressure balloon, 15.
Not the same one we have.
It was prepared.
We'll have a 20. That's fine. 2.5 20 is good.
Okay, good.
Give the ones we have
It's just
right now.
that you want a high pressure. 2.5 15.
All right.
And this 2.5 is for the diagonal or for the LAD?
No, we are doing the LAD at the level of the bifurcation. That is where we never did OA. OA we did from LAD to diag. So this is distal to the diag where we are having 2 ruptures.
Right, so that's the area that wasn't
So we are
ablated.
going to go 2.5 15 focal high pressure balloon.
Did the balloon expand? You had the 2.0 balloon
It did expand.
Dilated in that segment.
Yes.
It did
It-
expand.
Expand
So-
but ruptured.
Expanded to like
But it was
12
ruptured,
atmospheres, but rupture at 18 atmospheres. So there you go.
I think imaging could be very important now, based on if you're saying the LAD territory is still viable, we're still treating it with pretty small sizes.
Okay, good.
We need
Okay,
to get an
we will
accurate
go.
sizing of the LAD and be more aggressive.
Oh, Sina.
Yeah, so this is a stepwise
15.
approach, but I
Oh,
agree.
18,
You're not going to
20.
end with 2.5 here. You need much larger.
All right. Well, with the 2.5 15 at 15 atmospheres,
Now we'll do
looks
IVUS.
like expanded well. You want to inflate a little bit more distally?
I'm going.
Yeah, we're going a little bit more
Now
distally.
don't go crazy pressure. There's no calcium there.
10.
Yeah, and that's why everybody on the panel was talking the same way, I think, about the imaging, because as you go down with the balloon and at 15, it would be nice to know what the vessel size
we'll do the
is or
IVUS
about.
right now. Okay.
Yeah, they'll do the IVUS.
And we're preparing for IVUS again. IVUS. And we're doing we're doing again the dilation in the proximal with the same balloon, 2.5 at 20 atmospheres.
So that would be a very long stented segment here.
Yeah, I think the IVUS will help us understand exactly the answer to your question regarding the 1 or 2 stent at the LAD diagonal bifurcation.
Okay, get us IVUS.
But no matter what, the LAD is a diffuse diseased vessel, so it'll look a bit...
Yep.
Well, you're never going to get a perfect result.
Yeah, so we have to expect to start...
But on the last, after the dilatation, the LAD looked a lot better. The diffuse disease sounded much less diffuse than we originally thought.
Exactly.
Do you want a 3O high pressure? For the proximal
But,
LAD.
you know, in the old days, I know Gus was preaching for spot stenting or focal stenting. I think this is not relevant anymore. We have a very long stents. They behave well.
That was really more for bare metal stenting.
Yeah, or first generation.
Yeah.
But I think now, I mean, the longest stent that you have right now.
Yeah, that would be nice to see the actual, to have seen the angio, well, maybe on cine, because
Yeah, we'll see.
the LED it looks like a bit...
What's the creatinine? I forgot.
0.9, bring closer.
0.9?
Creatinine is not a problem. It's actually pretty good. So we're going distal, very nice delivery of this IVUS system. 60 megahertz transducer.
Yeah. Start pulling back.
Start pull back, please, and you can...
Show the IVUS live.
Yeah.
Yeah, we see the IVUS.
Indeed, a diffuse disease vessel down there.
Yeah.
I didn't have the flash to help
you
you
have,
out.
but you have lumen.
You're there? Now this is a lesion, so it's hugging the vessel. The vessel diameter is really 2.5. Not really
2.5, and it's still circumferential ring around it, which means I don't see, from the ballooning or anything else, do you see a big...
You don't see much of the breaks.
I don't see that.
I don't see either.
Yeah, so Jonathan, you're expert in OCT and you're doing a lot of OCT.
Yeah.
Tell me if you can see, I know you see the cracks after the shock wave.
Yeah.
But do you think that you can see also cracks after any of those ablative devices?
Absolutely. You see a gouge out of one side of the vessel. We certainly see it frequently with rotational atherectomy. I don't have experience with
we saw
orbital.
the cracks in the proximal lesion, the proximal LAD. The vessel size there is about 3O.
Proximal looks like 5 to 4O, right?
But there's a circumferential tight ring
Proximally
beyond the diagonal here, which needs to be either more orbital in the distal LAD. I think you need more calcium modification beyond the diagonal, so you have to take the diagonal wire out and treat that segment, because it's certainly, we saw with the balloon beyond the diagonal that it did not expand. There was a waist on the balloon which didn't give.
Yeah, that's the thesis, that unless you have that opened up more and cracked to a certain level, whatever fragment it is, all what you have done earlier maybe for not, you have to be able to expand the stent better.
So this shows you absolutely need further calcium modification, and in this case with orbital beyond the diagonal.
The problem that a lot of the operators get fatigue.
Yeah,
and they do the main one, they gratified by the proximal lesion, and they say, okay, it's anyway diffused distally, I'm going to leave it alone.
No, it's not. I think there is a big vessel there. It's just that it needs to be opened up.
And for Ziad, I didn't see it to be much better.
It was better. Actually, this is worse than the previous picture.
That's because the calcium is not taken up. It was recoiled following the immediate balloon dilation.
Defy recoil, right?
Yeah, so that's the problem. It needs to be
I will do 2.5
calcified somehow.
Yeah.
Maurice, there was a picture before this which showed it.
2.5? No, 2.5.
I'm wondering whether nitroglycerin may help there, just to kind of see because we
the next topic, you did balloon.
I need to dilate something here. The
Okay,
middle 80.
275.
So you did a balloon and you're not happy with the results of the balloon, and you see by imaging that you still need to do more ablation. Is that safe to go now with OA or RA?
I think it is safer personally to do RA with a 1-5 bird than the OA. That's my personal experience.
So you just in imaging. Imaging looks like it's probably safe to do it.
Well,
Yeah, right
Can you
now,
feel
let me tell you,
safe to go with
well, we're
with
very
OA
concerned.
after balloon?
We're very concerned about the distal part of the LAD where we have no balloon that continues to be in the
275,
2.0 or lower long string, as you see there, and that is not the best outflow. So we're going to do a little bit more gradual dilation and hopefully to
Let's make a
improve that
decision.
part.
So if we think we need to do atherectomy, then we have to switch to, I would say, rotational atherectomy with a 1.5 burr into the LAD.
Yeah, that's what
Yeah,
Boris
you
said
said
as well.
1-5 or
Not 1 to
1-5?
5.
Even 1 to
1.25.
5.
Yes, 1-5
1.25.
per. Yes, in the LED, and I think
But
that
we already
anything
have a
beyond the
lumen.
origin of anything
Look at the lumen.
beyond the origin of the diagonal, I think the rotational may be a bit safer.
Yeah, the issue with the 1.5 to the 1.25, I don't think it's the sizing. It's also the potential for more distal particles coming down. So the lower you use, they're probably going to have less distal embolization.
Any harm in giving IC nitro? I know there's AS, but
We can give a little
Well,
nitro
but you have
give
an
it, we can
impella,
give it.
so you're
Okay, go.
protected now.
After
It's
this balloon,
275, right?
after this balloon, we will do a little.
This is a 275 now. Oh,
Okay.
18,
80.
20.
There's a
Yeah.
lot of
He's up there.
recoil in the LED,
Yes.
right? A lot
He's
of
up there.
recoil. I think
That looks better.
at this point, if you're worried
He's up
about
there.
pulling the wire on the diag, do you at least try a balloon aggressively distally to start? If you can
No, we will.
modify it with
We'll
a
take a
balloon,
2.0,
you might
no,
save
2.5
yourself
you want?
Two-
coming
two
out of the,
five,
of
two
the
five,
diag.
No,
Okay,
I think
down.
that's reasonable. If you're worried about
Or one
rewiring,
more down at 10 at
rewiring shouldn't be that hard. I think. It's straight.
Here's another question to see how much we agree or disagree.
10.
You know, you may end here if you do further down the LAD with stenting through the entire vessel, almost to the apical
Down.
area. So you have the option to stop at the middle of the vessel to
Yeah.
take, this is what I have, and to say, I
You want to
supplied
use
the
some
blood
nitro.
to the diagonal, maybe another branch, few septals, I'm done here, rather than to go with full metal jacket all the way to the apex.
Probably it's not that bad thought because when we were talking about diagonal LED, which is primary, which is secondary,
Where is the 2 to
the
5 balloon?
diagonal would seem to be more
22520 balloon.
viable,
You want to
at
take a
least
2
larger vessel.
30
Yeah, and
balloon.
Morton Karen told me yesterday or 2 days ago that there is no point even to do FFR very
Okay.
distal vessels because we don't care. So if he doesn't care about it, then why should we even worry to stent it?
Fair enough.
He said,
Okay,
amen.
let's dilate
Oh, there he
distally.
is.
I think we have a very good
See, I'm
result
learning
in the
from you. I always
bifurcation
learning
level.
something from Mort.
And we're going to do a little bit more massage of the more distal part of the LAD with a 2.0 balloon.
Okay,
Before
Jonathan,
we-
you have drug-coated balloon in
Yeah. So we
England, right? In the UK, you have drug-coated balloon. We do not have it. Would you use here drug-coated balloon?
Yes, I think probably after I've stented the proximal segment and given some nitrate, seen how the vessel has come up, make a decision about DEB at that stage.
Yeah,
Probably,
we
but
gave
not
some
at this
nitrate, by the way.
Yeah.
The pressure now is 110 over 50.
What is photo means what?
I'll tell you one thing. I'm very glad that you have an impeller there because you don't have to worry anything about hemodynamics right now.
Well, this is to
You can
answer.
ablate as much as you
You
want.
can do a small
Okay,
balloon
now.
here and just wait a little bit and see how it looks.
Okay, what's this?
Just
Go. Low pressure?
Low pressure, like 6.
This is a 2 or 30 balloon, just low pressures to see that the distal LED will open up, will have a better flow. If we have a better flow, which will be now after we do a balloon, then what should be the stenting strategy? Provisional stenting or 2-stent strategy for the diagonal and LED?
So again, the question is, what's the goal? It's not just about the cosmetics. It's about reducing symptoms. If the patient has
Okay, down,
symptoms,
down.
is they coming from the diagonal? Or
One more back.
it's hard. I mean, how
Half
old
a
is the
length back.
patient?
82.
82.
Yeah, we're talking about
16.
quality of life for someone with
16.
aortic stenosis. I would say that, you know, You can argue that many of those patients, if you fix their valves, they're going to be fine, despite they have coronary artery disease. You don't have to do even hybrid. Because one of the areas that surgeons still take the patients because they do revascularization and the valve replacement, but I'm not sure you need
beautiful. I was going to say before the procedure, before the angiogram, I would vote for provisional stenting. And if after the angiogram, I'm still proud of it.
Yeah, I think you can
I would go for
a
two-stent strategy, mid to distal, and then stent of the prox LED.
So what does the
But there's
panel
nothing
think?
wrong to change your idea.
Yeah.
What the panel thinks about all these results? The distal LED was a key. The dilation was very nice.
We are impressed.
I think it's a beautiful result. No dissection, good flow, both vessels.
So again, if we were in Europe, probably we could have done here drug-coated balloon to prevent restenosis.
Yeah, that would
right.
be.
Yeah, do you have it also?
Yes, absolutely. And we had a long symposium on that today. And really, this is the and the paclitaxel apparently gets into the adventitia and gives you positive remodeling with time.
Okay, so I'll challenge you on that. You know, you have a lot of calcium there. And how much of the drug will go into the calcified area?
That's a good question. No one knows, really.
Yeah. LED?
Over here, 27530.
Too long.
Yeah, because we need to.
No, we go like that.
275 balloons.
You can take something in the middle. You're always going to be okay. Because you can expand it more if you feel that you were...
Yeah, no, we're going to extend it proximally to the 3.0 all the way to the proximal LED. There's no question about that. So we're going to use 2 stents, 2.5 and rather long, synergy type for both of them.
Okay, another question to the panel or to you.
2524.
You have the option to use a very long stent, let's say 42, 48.
32 and a 24,
or to use, which would be one size, or to use 2 stents, one 275 and 25, or 130 and 25. What would you rather do in a situation like this vessel? Because this vessel definitely tapered. We saw it by...
You can take the longest because between 2.5, 2.75, you can go up to the size that you want, post-dilate.
So you'll take a 2.5 and you'll expand it
long.
So the
one long stent.
So the 2.524 is going to go to the diagonal.
Try to avoid overlapping at the diagonal.
And the 2.532
is long,
going to
but
go
where
to
do
the
you
LED.
start towards the apex? How far down do you go, and where do you land? Classically, you cover what you dilated.
They dilated the whole.
They dilated the whole thing. Yeah.
I wouldn't go that.
Yeah, but that's a lot.
Go all the way there.
That's fine.
I think you have to select your landing zone with intravascular imaging and choose it precisely. And if you can do that with HD IVUS, then you just mark your point with a fluoro grab at your when you've got the IVUS in the right position.
So what is your 2-stent strategy?
2.524 in the diagonal.
What type of 2-stent strategy are you going to do?
2.5.
Yeah, mini crash.
2.5 in the
mini crash, yeah.
We lost audio, I think, from Kenny and George. Oh, here we are.
Mini crash.
Kenny?
Mini crash.
Mini crash.
Yeah. So what we have a 2.524 in the diagonal, and we are going with a 2.532 in the LED.
I think more importantly, whether one long stent or 2, is to try and avoid overlap in the of where the side branch is, and to know the extent of how much you can dilate your stent.
I agree with the comment that Ziad said. I would go for long stent because I don't like the overlapping period, and also don't to miss between the two. So,
and if you are going to overlap, it's better to be more longer to
give beautiful
room for more proximal.
Agree? Okay, go.
We can come a little bit back if you want. All right,
this was a younger patient. You should leave some room for the surgeon to come later on.
12.
For an elderly, you have to leave room for brachytherapy catheter to go down.
There.
One more inflation.
Yeah.
Why is a red blood pressure?
Surgeon with what?
It's okay, don't worry. The femoral is good.
can also
The guy
come
has too much equipment.
80, how much?
No, it was a younger patient.
Younger patient. Because
so, Kenny and George, you have about 4 minutes remaining. I just want to give you the timing. You know, rush. I mean, we're enjoying watching you and discussing with you.
No, die.
And you're making a very nice progress.
Go.
Me?
Too bad. Go up.
All right, so now you're seeing mini crash.
1 second.
Take the wire.
Remove the yellow wire. Remove the green wire. That's good. Let's test.
Go.
Very good, guys. Don't ask us all the questions at the same time, then we don't know which question to answer. You can see the steps. Very simple. The diagonal stent went up.
Good. Down.
The balloon was deflated.
Then, SDS and everything.
Then both the balloon and the wire was removed. And now the LAD stent went up.
Go up again.
And with a second inflation.
If you need the steps known better, we can open the Bifurcate app.
Yeah, and then they removed the wire, and there is the Bifurcation app that was developed by Kinney and her fellows.
All right, let's take a little picture before we take the 3.0 stent.
Go. Nice.
I will take the 3.034.
Okay, now we will recross KISS there.
So, Maurice, would you stand all the way to that distal diagonal, or whatever you want to call it?
I would do more than this one, perhaps, but whatever it is, I'd like to know what's happening beyond the stented segments of both LAD and diagonal.
Yeah, a little
There's
spasms
there
and things
too.
like that.
Yeah, maybe it is spasm, maybe it is not.
But that may
so
resolve.
that's what I'd like to know.
Imaging,
correct.
Nitro.
high pride. A little bit.
I think if we give vasodilators, the distal vessel will wake up.
Yes.
Well, vasodilator is also time, so then
Yes.
do the proximal stuff and see how the imaging looks over time. It might get better.
Okay, give me a
So then-
212 balloon.
Maybe I'll be surprised if it's plumb.
2.012. So the most
We
important
have 1
step now
minute
is the
remaining,
recrossing.
so
And you see
Now
when
is
it
the tough
recrosses
part.
like
Recross
that,
is beautiful.
when it
Very
recrosses so
easily.
easy,
Yes, and
you
give
know
me a
it's wide
212
open.
balloon.
yeah, you're going to be fine here.
And then give
And
me
you're
a
gonna do
LED.
kissing
275.
stenting.
The 275 balloon. So we will use the
So
275.
we're going now with a 2.0 balloon in the diagonal to open the stent strut and do a little massage distally. And then we'll do the kissing balloon and following up with the final simplest step, which is the extension of the stent in the proximal vessel, which already is fine. And you can
give
see
me the
how easy
275.
it crosses.
Okay.
Everything has gone very, very well. And according to the Bifurcate app, let's take a picture.
And when you are done with this
Well,
procedure,
this
you
to
will
take a
remove
little
the
massage.
impella. Is that
yes.
correct?
Yes.
Yeah, in
You,
the
you
end,
remove it in the cath lab.
We'll remove it
And
in
how are
the
you going
cath
to
lab.
close
We
it?
have
You
a
have to
pre-close.
pre-close?
Yes.
yeah, we have two pre-closes, and the patient is on heparin and
I think
clopidogrel.
that's about
And
I think it was a very nice case. Not an easy one, and we can argue. I don't know, Jonathan, did we
goodbye from
convince
New
you
York.
about impella here?
No, it's fine. I mean, it was great.
You okay with
It took
that?
all the stress out of the
Which is
case,
this
but
one?
I would have
Mine
loved
is
to
the
have seen
diagonal.
some more detailed
go with the
imaging.
diagonal.
I think
All of us want to see
Yeah.
more detail, that's for sure. So, thank you, panel. I
14.
think we're going to move to the next session. We're going to have more live
All right.
cases from
Go,
the
high
Washington
pressure.
Hospital Center today. So stay tuned.